My case is about a lentiginal cyst with root resorptions. These are the authors. I'm from University of Santo Amaro in Brazil. Our patient is a 30-year-old male, RC from São Paulo in Brazil. His medical history, we don't have any we have only childhood diseases, not any one other disease important. No history of hospitalization or chronic illness, and he don't take any medication. As such, Tylenol for headaches and something like this. His family records don't show anything important, and in the history of the disease, he reports that began to feel something in the left side of the face 6 months before he came to the university to find his treatment. It was strange because he don't have a specific thing to say for us. He has only that he feels something. It's very strange. This is the X-ray, the orthopontomography field, or panoramic field. We can see a huge destruction in the body at the angle of the mandible on the left side, involving the crown of the third molar and resorting the roots of first and second molars. We can see also a possible perforation of the lingual cortical in the dark sides. In a more close view, we can see the important root resorptions, the perforation of the lingual bone, and the possible cyst involving the crown of the third molar. Then we asked him to make a CT, and this is the cuts for CT. We call this dental scan. It's a kind of reconstruction in CT that we use in Brazil, showing the resorptions. These are the other cuts in our CTs, showing the huge destruction in different sites. We can see also here. We can see also here the resorption and perforation of the buccal sides. In this view, fenestration of the buccal or vestibular and lingual corticals, and we can see also a little thin part of the bone in the base of the mandible. This is another view of the CT. And then, with these images, we made a differential diagnosis. Is it an lentiginal cyst with root resorption? Is it an ameloblastoma, a central giant cell granuloma, primary malignant neoplasia, or a metastatic neoplasia? Obviously, and he's a 30 years old man, it's not so common to have a primary malignant neoplasia, such a carcinoma. We don't have an image that feels it was an osteosarcoma. We thought that the lentiginal cyst is the best shot. But we have root resorptions. And then we thought that the best thing to do is to make an incisional biopsy to plan the treatment. We used to plan the treatment and plan the reconstruction at the same time to give the best quality of life for the patients that we can. We made an incisional biopsy, and the result was the lentiginal cyst. Then we planned to make an intraoral approach to remove the cyst, remove the teeth, because of the resorptions. It's impossible to maintain this teeth in the mouth. And our option via an intraoral approach is to make a surgery that was a little scarce for the patients, and the best that we could do. That was intraoral approach, extracted the teeth, and then before we made the cyst, we treated the cavity of the cyst. We made a graft with Ostin 35. That it was an hydroxyapatite, nanoparticulated hydroxyapatite paste. We use it a lot. It's a really good material to make grafts in sockets that you have 3 or more walls. And we put a collagen membrane over the graft to protect it about the soft tissues. These are the orthopontomography 4 months later. We put this plate in an intraoral approach to prevent pathological fracture of the mandible. It was difficult to put this plate, particularly the screws in the top of the ascendant realms, but we made it using an angulated handpiece. This is the orthopontomography 8 months prior to the surgery. We made 2 dental implants to rehab our patients. These are the healing abutments. The crowns, we opted to make 2 individual crowns. And these are the final slide. Successful rehabilitation in our patients. He had a huge cyst. We opted to do it by an intraoral approach, graft with synthetic graft material, such as hydroxyapatite, made a plate by intraoral approach, 2 implants, and 2 crowns. I think that he had the best treatment that we could do for him. Thank you very much. This is my email. If anyone had to send me an email to talk about diseases or maxillofacial surgery. Thank you very much.
Thank you very much, Professor Da Silva. Are there any questions for Professor Da Silva?
One question that we would maybe have a different approach, although I think your results was excellent, to marsupialize the cyst and wait for it to be smaller and that you can remove it easier and maybe maintain the teeth. What is your opinion on that as an alternative?
In big cysts, we used to marsupialize also. But in this case, in my opinion, the resorption of the roots are so big that it's impossible to maintain this leaf. So they have to be extracted. And also, we had to wait 6, maybe 8 months or more to turn it, to make the size smaller, to make the smaller size. And it was very, very, very bad for the patients to stay with a rubber drain inside his mouth. The smell is bad, the taste is bad. I think that if it's possible to fix it in one surgery, I prefer. This guy, in 20 days, maybe 30 days, he had with no disease, and he was okay. And maintain a drain in his mouth, I don't think it's the better thing that I can do for him.
Thank you. Do you have any other questions? Professor Da Silva, may I ask you a question as well? Do you think that you could have managed this slightly differently instead of having a large reconstructive plate placed onto the jaw, by immobilizing the patient for a period of 2 to 3 weeks, which would have been sufficient to give you sufficient stability of the mandible?
I think yes. I think that it's possible to don't use a plate and immobilize the jaws for 2 or 3 weeks. That I think it's possible.
Thank you very much for an excellent presentation.